of diagnosis, we have a few goals, training objectives that we're going for. The definition, the basic idea of what diagnosis is and how we go about doing it, how it's done in Valent through the context of the DSM, and then a discussion of some issues that tend to be sticky aspects of the diagnostic process. Can everybody see the slides all right? Yes, good, okay. So we'll start with the very basic definition of a diagnosis, which is the process of identifying and classifying an individual's mental health condition based on an evaluation of these three things: their symptoms, especially the symptoms that they self-report, their behaviors, both behaviors in person and, again, what they report, and any psychological patterns that can be determined. And so for the purposes of diagnosis at TCN, this means identifying the most appropriate diagnosis in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. I think different clinicians place, a different priority on the DSM diagnosis, but I'd like to make a pitch for why a diagnosis is important. First, a diagnosis helps to inform the treatment plan, right? You want to base your goals on, fundamentally what's going on with the client, and I believe a diagnosis is critical for that process. It also provides a standardized language that can travel across domains or across practitioners. So it's a shorthand, no doubt about it. It doesn't give you the big picture, but it gives a snapshot amount of information that can be shared with, med providers, therapists, social workers, home care workers, and there is utility in that. An accurate diagnosis also helps to educate our patients and their families about their disorder, especially if we're working with children. And it can actually help in the compliance with treatment if they have a clear understanding of what's going on with them. And a diagnosis finally can identify the need for extra support, such as vocational training or support groups, community resources, and the like. So it is important to put some time and effort into the diagnostic process. So how do we come about with an accurate diagnosis? Well, there's a lot of different ways, but these are the four big ones. The first one for all of us, happens in the initial eval session, right? It's the clinical interview. Obviously, that's where we get a lot of the background history, the symptoms that they're reporting, understanding any life stressors that may be impacting their well-being at the time. But we also want to rely on our direct observation of what we see in the room. So we can often see a demeanor or a behavior or things like speech patterns, real-time behavior that can inform our diagnostic impression that may not be captured through self-reporting. From time to time, there's collateral information. Now that happens very frequently with children, right? So parents come in and they're giving you collateral information, but you can also get reports from, step-down reports from IOPs or hospitalization. Sometimes you can get them from schools, or sometimes they can bring in collateral information. Anything like that can be very useful in informing your diagnostic impression. And then finally, we have assessment instruments. And something that I think a lot of people at TCN don't know is that Valent comes with a fair number of assessment instruments, some of which are actually industry standard. So we're pretty lucky to have these. And I'm here to encourage you to use these diagnostic tools. I mean, they're fantastic instruments, and I'll go over just a few of them. So this is just a brief list that I've created that I think are some of the most useful and just very easily accessible in Valent. If you don't know where it is, it's in the little hamburger shape icon, the little 3 lines in the top right corner. You pull that down and you can add an assessment instrument right from that list. What's kind of tough about it is it uses abbreviations, so you don't know what all of them are. That said, here's a few that I can lay out for you. The first one is a general DSM-5 screen. It's only 23 items. That's a very useful item. If you suspect ADHD, the ASRS is a very good adult ADHD screen. The GDS-30 is excellent. This is industry standard to assess depression for our geriatric patients. The Hamilton is another like industry standard instrument that looks at the severity of depressive symptoms. I can encourage anybody who has potentially depressed clients to look at the Hamilton. The Mood DQ, it's called Mood DQ and it looks like mood disorder questionnaire, but it really is focused on identifying bipolar. And this one is pretty accurate and it's only 13 items. The PCLC is the civilian PTSD checklist. So if you have a client that you suspect may be dealing with trauma symptoms, this is one that I recommend. There is also a veteran version in there. So for any of you who take TRICARE and you might have any veterans in your caseload, there's a veterans version as well. And then the Yale Brown is a very good tool to assess, at least as a screener for OCD. And then these are some of the ones for children. These are fantastic. The CESDC depression scale, very accurate. The child behavior checklist. Now that one's a biggie. That's the one biggie. That's 146 items. This was one that you usually give to parents. It takes about 20 minutes to do, but it is comprehensive. That is a powerful instrument for anybody who works with kids. The Yale Brown also has an OCD scale for kids. The pediatric symptom checklist, that's another industry standard. That one's only 35 and gives a really great snapshot. The SCARED is very good for anxiety disorders. And of course, the Vanderbilt, everybody should be familiar with the Vanderbilt. That's another industry standard for ADHD in children. This is not comprehensive. I mean, there's actually like 4 times as many as this. These are the ones that I believe are sort of the go-to instruments for what we have in Valent. Now, the idea is to eventually pick 1, 2, or 3 disorders that reside in the DSM-5. DSM-5 used to be a 5-axis model, so you had, axis 1 disorders and axis 2 disorders. I think they were smart in getting rid of all of that and just condensed everything into a single list. These are just the different categories. So the DSM is a very robust document filled with a lot of diagnoses. So even if you're a long tooth like me and you haven't cracked open the DSM-5, or if you haven't reviewed it since the DSM-4 TR, I actually recommend it because there's quite a lot of changes. And even outside of the diagnostic categories, there's a lot of very good research-based information about sort of the larger picture of some of these categories. Like an example of that is autism, where autism spectrum disorder and Asperger's disorder have been condensed into a single autism spectrum disorder. But it goes over why they did that and how to assess for that. And there's really excellent information in that book. It's not a page turner at night, but it's a good thing to review over time so you get an idea of the logic behind the DSM. And I just threw this in because I thought it was kind of interesting that these are, as of I think the last 2 or 3 years, the most common diagnoses in the outpatient population. Interestingly, there's a little bit of difference between men and women. Both, number one, is generalized anxiety disorder. Is anybody surprised by that? I'm not. And then, of course, MDD right there at number 2. That doesn't surprise me either. But here is where it starts getting interesting. Number 3 on the men's side is ADHD, and on women's side, it's PTSD. And I think that's telling of something. Followed by adjustment disorders, and I'll go over why I think that is. Followed by substance use disorders for men, and then bipolar for women. Keeping in mind, okay, that I believe that there are trends and fads that can happen in diagnosis within sort of the larger mental health provider population. And I can look back and remember trends where everything was ADHD, and then trends where everything was bipolar. I think that can happen. I think there can be biases from different diagnostic providers. I think that may be what's going on here a little bit. Another thing that I think is going on a little bit, yeah, I'm with you there. I actually think that would be a little higher, but we have a bias against ADHD in women, right? We see men as having more ADHD-like symptoms, and because we don't really use a lot of assessments, a lot of times people just use their best guess or what seems to sort of intuitively make sense in the room. That's why these assessment instruments are so important. But the adjustment disorder, I actually don't think that's there, because adjustment disorder is the 4th most common diagnostic problem. I think it's there because adjustment disorder tends to be used as a fill-in for other diagnoses when somebody doesn't want to put in something more severe. And we're going to go over that a little bit later, but that's why I think that's number 4. So now let's go over these 5 diagnostic issues that tend to come up. And these are all equally important. So one thing you might hear about, these are 2 different important terms to really learn when in the diagnostic process. The first one is differential diagnosis. And all that really means is that quite often it's the case that a patient comes in and their collection of symptoms that they're either self-reporting and that you're seeing could apply to more than one diagnosis in the DSM. So common pairs that, oftentimes it can, either go one way or the other way, is generalized anxiety disorder or OCD. Sometimes symptoms can go to one or the other. Another one is ADHD or PTSD. This is really common with children. And from my own experience, I used to work with traumatized children a lot. And by the time they got to me, I would often get collateral material, and they would actually come in with a diagnosis of ADHD. And it didn't take me, a couple of weeks to figure out that was an incorrect diagnosis. And in fact, they had PTSD. And what looked like just inattentiveness was in fact hypervigilant behavior. So it can be tricky to make those differentiations. You have to develop a fine eye first to know which diagnoses can look alike, and then how to tell those subtle differences to lean one way or the other. Major depressive disorder and bipolar can often be tricky to figure out. And what's really rough is when you actually do have 2 going on at the same time. So in fact, when you're actually looking at a comorbid situation, right? So it is possible for a child, right, to have ADHD and PTSD. Those 2 things could exist at the same time simultaneously. And when that happens, that can be really tricky to figure out, and it makes it double tough for care, like especially in the case of ADHD, and PTSD, because the medication for ADHD is actually not the best medication to have if you have PTSD. So this is probably one of the tougher aspects, especially with kids who have a harder time like articulating clearly what they're experiencing. A lot of times we can only go by behavior. Now, we also have to look at the developmental context, right? We have to figure out, well, what is potentially a mental health issue and what is sort of typical development, right? So it's not uncommon to work with, say, adolescents who might be coming in, and let's say they genuinely do have a mental health concern, but then somebody puts down bipolar because they're moody, not realizing that most teenagers are moody. that's actually appropriate developmental behavior. So it can take a fine-tuned eye to recognize the difference between a genuine mental health concern, something that requires treatment, and what's just sort of normal, ordinary developmental behavior. Now, the process of all of this, it gets tricky and it's case by case. So I don't want to present this like a one size fits all. But when you believe that there is a differential diagnosis need, it really does require a thorough evaluation. At that point, it's not enough just to take self-report. That really is when you want to start using screeners, right? So that you're digging into the assessment instruments available to you in Valent, so you can really start, well, literally screening for what you think it might be. Now, you also need to rule out biological concerns very often. Now, I'm going to give you an example of that from my own practice. I had a guy who I was working with for like a year. I'm almost embarrassed to admit this, about a year. And he was dealing with anger issues. And we were digging into relationship with his mother and just a lot of deep psychodynamic stuff. And I don't know why it took me a year. But after a while, I asked, hey, how you sleeping? And it turned out he only got like 4 hours of sleep a night. That was just sort of the habit he had gotten into. And once we realized that, I started working with him to help him get 7 hours of sleep a night. And lo and behold, within like 1 month, his anger issues had diminished to the point of being able to leave treatment. So I mean, I'm not saying any of that other stuff wasn't useful. I think it probably was. But a lot of times our clients can be going through things that are physiologically based and not just psychologically based. So it's always important to talk about, well, how's your diet? How's your sleep? Are you under a lot of stress, right? How much exercise do you get? Those things are really important as rule out factors. And so I already talked about comorbidities, and to at least be open to the idea that if there are multiple diagnoses that seem to be in play, that it's not necessarily one or the other. And when that happens, you want to go into a rule out situation, and we'll talk about that. Cultural competency, I have to underline this. This is something that, in my opinion, needs to be a lifelong feature of our education as providers. There's no such thing as becoming like fully competent culturally. That doesn't really exist. It's something that we always need to be practicing, being mindful of, and trying to improve. We always want to be able to take diverse cultural backgrounds into consideration especially when we're entering into the diagnostic process. Because cultural backgrounds, they can influence how symptoms are expressed and perceived by us, right? Like, we're not outside of culture. We have our own culture that we bring into the therapy room. So we want to be mindful of what culture we're bringing into the diagnostic space. So this can affect how psychological distress comes across. Sometimes it's physical, right? It may be physiological or somatic, right? While others, it may be very emotional and expressed through affect. These are the kinds of things that we need to educate ourselves about. So we need strong cultural awareness. We need to recognize our own personal biases, or at least to recognize that we have them, even if we're not aware of what they all are, and an understanding of the cultural backgrounds of our patients. I'll give an example, another one where it took me a while to learn. I had a client who was an immigrant from Iran, and I don't want to say naturally, but I had my own biases about what that meant. And over time, I learned a great deal about how this client actually didn't really identify as Iranian so much as Persian, and the background of that, and what their family structure is like, and what personal expectations were like. I mean, there was a lot of work that had to go into understanding the cultural background that she was coming from, so I could understand what she was going through. This is something we always need to be mindful of. So we want to develop that cultural knowledge whenever we can and be open, right? We want to be humble culturally and be open to information about our clients' cultural backgrounds. And of course, over time, we want to develop our own cultural skills in being culturally sensitive when necessary. So I've talked a little bit about diagnosing children, but kids really do have their own unique challenges in terms of diagnosis. Mostly because unless they're older, unless they're, maybe 15, 16, 17, you're going to involve parents a lot more, right? A lot of your diagnosis is going to be based on what they have to say. So you need to be able to engage with parents or their guardians, and it can be extra tricky because now you're going on like a secondhand report. You're not getting like the kids firsthand report of what they're going through, but what a parent is seeing and their own interpretation of behavior and mood and psychological functioning. So you always want to, or I strongly advise anyway, to take parental information lightly, right? You want to take what they're saying, but then use your own judgment over time to see how accurate it is. Because anybody here who works with kids, you know as well as I do that a lot of times when a kid has mental health or behavioral problems, that the apple doesn't fall too far from the tree. So there's often a dynamic going on there, so that your diagnosis isn't just about the kid, but it's about the caregivers as well. We'll talk about that at the end a little bit, but it's always useful to remember that you want to take parental support with a little grain of salt. Okay. We talked a little bit about developmental considerations, right? But you want to do that through the whole lifespan. Well, I mean, you want to do that through the whole lifespan, right? All the way up through geriatric. But with kids, especially up until around age 22, you really want to keep in mind where they are developmentally and how that's what role that's taking in whatever their mental health or behavioral concerns are. And again, I just want to double up on this to avoid misdiagnosing what is normal developmental behavior. And then we have, of course, the family and environmental influences. So we always have to look at, what's the family dynamic, right? What's the school environment like? What other social factors might be in play? Because I think more than adults, kids, are so susceptible to all of these forces around them that they can't really influence, on an equal measure. And so we have to assess for their environments as well. Excuse me. So a diagnosis can have a really big impact on a client's life. Now, if you have a patient who's coming in and they're well therapized, they may be very comfortable with the diagnosis. They're coming in with the diagnosis. Um, uh, in this case, it's going to have maybe less of an impact. But in cases where somebody is coming in sort of fresh into therapy, getting a diagnosis can have a very large impact. It can have an emotional impact. And that can range from relief, like, oh, finally, I know what this is. At least I got a label for it. But it can be fear, like, what does this mean? Am I ever going to be normal? Am I ever going to be okay? Am I always going to have to be on medication? There can be a lot of anxiety that comes from that, and there can be a sadness. There can be a sense of loss. If I learn I have a diagnosis, especially one that may be biologically based, like bipolar or schizophrenia, right? That can come with a lot of sense of loss and sadness. So, yes, there can be clarity and understanding, but it can also be overwhelming. And we always want to pay extra attention to that and be prepared for how our clients are going to respond. Now, in some cases, there can also be a stigma. Now, as we're all aware, the taboo around mental health has been lifting in America for some time, which is great. We love it. But it's not everywhere. It's not universal yet. So some people can experience a sense of stigma or perceived stigma by having a mental health diagnosis. This is not uncommon with kids, especially teens who all just want to be, normal, whatever that means. And in their minds, having a mental health diagnosis isn't normal, although it's pretty dang common in reality. Uh, but for, a teen or a young adult, it can be distressing when they feel like they're, now in and out group. So we want to be mindful of that. It can impact one's sense of self, right? How our clients actually view themselves and identify themselves. It can impact their self-esteem. In some cases, they can take a diagnosis and interpret it as somehow characterological, like with ADHD, right? It's like, oh, I'm lazy. And it can take some education on our part to help them see it in a more accurate way. Now, it can also be important to have a diagnosis so they can have access to other forms of treatment. And so an example of that, Maggie, you might have to correct me because I'm not sure if this is across the board in TCN, but where we have interventional, where we have Spravato or those kinds of interventional options, a diagnosis is critical to be able to have access to those kinds of services, even within our own practice. So we want to be mindful about, when our client might need sort of a door opened with a certain kind of diagnosis. But the flip side of that is a diagnosis can actually have legal ramifications for our clients, depending, especially on what kind of occupation they're in, right? So some occupations, like, it can become okay. Thank you, Maggie. So yes, TMS and Spravato, that's across the board. So a diagnosis is critical for that. But we do want to be mindful when a diagnosis might impact our client's career. If they're a police officer, if they're a firefighter, if they're an airline pilot, there's certain occupations where it does matter. And finally, we want to keep in mind that a diagnosis often comes with, certain kinds of, our clients can have their own methods of coping with, especially news that was surprising to them. And that can impact not just their sense of who they are, but how they're going to live their life. So we want to be mindful of the impact that a diagnosis will have on their sense of not just who they are, but what the rest of their life is going to look like. Yes, thank you. Yes, it can impact life insurance. It can impact getting into certain kinds of educational opportunities. Yeah, it can make a difference. So we always want to keep that in mind. Okay, so here's a couple of other issues that I'm willing to bet all of you have come across one time or another. The one of the effects of the taboo of mental health decreasing and knowledge of mental health increasing, especially over the internet, is the frequency of self-diagnosing. It is so easy to go online and just put in your symptoms, and Google will pop back, especially AI now will pop back some diagnosis for what's wrong with you. Unfortunately, this may be a hot take, but I don't quite trust AI to diagnose our clients, and I certainly don't trust a brief Google search or a website. I see your hand there. We'll hold on to your questions. We'll have a little question and answer period at the end. So our clients can come in with all kinds of ideas about what's going on with them, and they can sometimes even be certain that they know what's going on with them, right? It's like Chat GPT told me that I'm bipolar. um, what I say with clients who come in to see me, when they have like a strong diagnosis where they've self-diagnosed, is to say, like, look, I appreciate that this may seem right to you, but I've been diagnosing patients for 22 years or whatever it is, and I am still mindful about the diagnoses I give. I am still careful with the diagnoses I give. And quite often, I will be patient with my diagnostic process. And I've been doing it a long time. And this is something that I consider myself expert at. Just because we can have, a menu style diagnostic process where you take your symptoms and, you know, which menu does it, fit under, the 6 out of the 8 in this category. Um, Believe it or not, that's not always the right answer, right? That doesn't always say adequately what's going on with your client. So I try to do some gentle education around the diagnostic process and how complicated it can be. They can even come in with a great deal of anxiety or stress when they believe they have a certain diagnosis, especially if they have like a severe diagnosis, right? They're like, oh, I think I'm borderline. That's happened to me. They were convinced they were borderline. They weren't borderline at all. They were dealing with some trauma. That's what was going on with them. It can get in the way of not only creating an accurate diagnosis, because they can come in. So, see, this can go the other way. So they can start doing a search, or Chat GPT might say something to them. So then they get it in their head that they have a certain diagnosis. Then they'll start learning about the diagnosis, and they'll learn about all the symptoms in that diagnosis. And they'll be like, oh, yeah, that's me, and that's me, and that's me. And they sort of have their bias now towards that diagnosis. And they can almost like create symptoms through their perception in order to attach to whatever diagnostic impression they've created for themselves. This is dangerous. This is something that can really get in the way of our clients' care. And if I want to get really fancy, the act of doing that can itself be a clinical issue. And that's something that I encourage all of you to like think of. If your client is coming in with a strong like attachment to a diagnosis, you want to think about that not just educationally, but clinically as well. And that leads into this other half, which is when they have an over-identification with a diagnosis, right? Because then what happens is they start interpreting everything about themselves through the lens of their diagnosis, right? It can really impair progress. Because they don't want to recognize progress, because that can begin to that can create dissonance, right? If progress is being made, then does that mean I don't have this diagnosis anymore? But if I'm emotionally invested in having this diagnosis, maybe because I get secondary gains from it, right? It means, by identifying and broadcasting that I have a certain diagnosis, I get certain kinds of attention, or I can say I'm a part of a certain kind of group. That can impair the therapeutic process. It can reinforce symptoms, or it can exacerbate symptoms. Like maybe they do have mild symptoms, but then it may become exacerbated into severe symptoms because they really want these symptoms to manifest, because now they've over identified with it. And obviously, it can affect relationships, right? It can really impact relationships when their ability to relate to other people happens through the lens of a certain diagnostic impression that they have with themselves. This itself, in my opinion, is a clinical concern. There's no diagnosis for it necessarily, but it is a clinical concern that we should always be paying attention to. Okay, finally, case formulation. This is our last slide, and then I'll open it up. Uh, Open it up to some questions. So it's important to make a distinction between a diagnosis and a case formulation. Okay, so the diagnosis, strictly speaking, really is just what is the diagnostic category in the DSM, right? A case formulation is a comprehensive overview of the client's history. Yes, symptoms, but also various contributing factors, physiological factors, psychological factors, social, the biopsychosocial web that they find themselves in, all to create a holistic understanding of where they are in their life, how they got there, where they want to go to, and how they're going to get there. That's a case formulation, which is much larger than just a diagnosis. But you need that diagnosis as part of the case formulation, right? So an important part of that is the exploring the etiology of a diagnosis, right? Now, to be clear, you don't have to have an etiology in order to treat a set of symptoms. You don't need to know where it came from. But when we can discern where a set of symptoms may be derived from, where they developed, why they developed, it can inform our treatment, right? It can develop more self-understanding on the part of the client, and it can help them like bring up, develop insight into where these patterns may have manifested in other parts of their life that they had never connected before. And the more that they can connect sort of this web of decision making and behavior and interpretation, the clearer they can become in terms of answering, well, this is how I got here. This is why I'm in this job or in this relationship, or finding myself being alone or unhappy, right, or scared. So by exploring the etiology of diagnostic symptoms, right, it can help lead them out of them. So that's an important part of that process as well. And as you go through that process of looking through, like, what are some of the underlying or originating factors of your diagnostic impression, it can actually, to go all the way like full circle, it can inform your diagnostic impression. And you can begin to say, all this time I thought you had, social anxiety, and now I'm realizing this is actually OCD. But a lot of times we can't discern that until we begin to pick up on these fine patterns of behavior and thinking and emotions. And the way we construct our case formulation, in my opinion, is usually best done through sort of the framework of a theoretical orientation. Doesn't have to, I'm not suggesting that. But when we have a theoretical orientation to guide us, it sort of like creates the tent hooks that we can hang our formulation on. So whether it's CBT or psychodynamic or existential or Gestalt or more specific ACT or DBT, REBT, whatever your particular form of expertise might be. This is sort of the model that you want to use to sort of frame your case formulation on. And by doing that, it creates a feedback system where the diagnosis informs your case formulation. And as your case formulation becomes filled in and more robust and more complete, it can actually then inform your diagnostic impression in a more clear and useful way. And that's it for the formal presentation. And I would like to open it up to any questions anybody might have. Thank you. Any questions at all?
I have a question, Dr.
Sure.
Foley. Let me undo my camera. Okay. Thank you again for all of your knowledge. Something I've always wondered is there a time frame where we should go back and look at a diagnosis when their symptoms have decreased and maybe now it's in like the criteria of in remission or along those lines? Is there a timeline for that, or does it just always stay?
Yeah, well, I mean, that's a really great point, which is we always want to be mindful when symptoms have changed, right? Where either they're now in a milder position or maybe even recovered from it and the diagnosis no longer applies. Um, yeah, there's no timeline so much as that's something you just always want to be sort of keeping an eye on. But you certainly want to do it at least every 3 months, right? Every 3 or 4 months at a minimum, you want to be able to take a look at are we seeing any changes in their diagnostic profile? Um, Now, speaking of that, there is something to keep in mind when thinking about adjusting the diagnosis. Now, this is for your patients who are also receiving medication services, right? So let's say you're seeing somebody who has a diagnosis of MDD and they're seeing one of our med providers and they are getting Zoloft, right? Well, you don't want to just take out the MDD diagnosis because that's the diagnosis that the med provider is using to prescribe the medication. So we want to be in consultation with the other providers in the client's care to make sure that we're sort of not undermining their care, right? So that's something that we always want to keep in mind. And even when that's not the case, when we have a shared client, we still want to be in consultation and at least reach out to any other providers and say, what do you think? What are you seeing? So that you can come to consensus, which is going to be more powerful anyway. Good question. Thanks, Jessica. I got a question from Alexandra in the chat. What makes you suggest the Hamilton over adult depression assessments? Well, I wouldn't say over others. Like the Beck is fantastic, but it's one of the industry standards. The Hamilton is highly validated, so it has a high alpha, and you're gonna get a pretty consistent response with the Hamilton. So it's not the only one you want to use necessarily, but if you use it, you're in good hands. Oh, and would I say it's worth making clients do both? Yes. So if they do the PHQ-9 and you're pulling for some depressive symptoms, then yes, the Hamilton would supplement it and give you greater insight. It's also useful for pre-test and post-test, right? So you can use it over time to determine if their symptoms are improving. Good question. Any other question? Going once, going twice. Okay, I'll let everybody have a longer transition period to your next clients. I really appreciate you coming to this training. It's been a privilege talking with you about this. You can always reach out to me if you ever have any questions about diagnostics. Maggie, where do they sign in? I think Maggie knows the answer to that. Okay. So yeah, scroll up in the chat and there's a link. That's important so you get credit for attending. Okay, so I will answer this one last question. For clients that have professions where a diagnosis could impact them, how do we move forward? That's a good question. You don't want to be dishonest, right? So you don't want to put in a false diagnosis, but you have to have some diagnosis, right? So whenever you do, one of two things can occur. One is you can have a conversation with them about it, and you may decide that putting in, the most accurate diagnosis really is the best choice, even if that could come with uh, some cost somewhere down the line. But you may also decide that you want to lean maybe towards a less severe diagnosis, right? And that is why I think adjustment disorder is in the top five or the top four of the most common diagnoses. I think it tends to be a filler when maybe other diagnoses are going on. It's also kind of a version of rule out, right? It's like, something's going on, but I'm still not quite sure what. So I'll just put in adjustment disorder. If you do, you just want to be careful about that, because if you forget that you've diagnosed them with an adjustment disorder, and then like 6 months have passed, and there's an audit, the insurance company may be like, why are they still in an adjustment disorder, right? It's been 6 months or 8 months. That's a long time to have an adjustment disorder. So if you do it, you want to make sure you're just putting it in temporarily. Okay. There we go. So Maggie posted the link to the sign in the chat. So I encourage all of you to do that so you get credit. And if that's it for the questions, I'll sign off and say thank you, everybody. And once again, I'm always here if you have any follow-up questions. And you're all very welcome. Thank you.